describe the anatomy of the model space. That is the first thing that we have to say. It's also called the sacral epidural space. Caudal, other name is also sacral because it is the sacral bone which has this epidural space. So sacrum is formed by the fusion of five sacral vertebra. It is a concave anteriorly, and it has a median crest. Fusion of all the sacral spinous processes are happening. And sacral hiatus is nothing but the caudal end of the median crest created by the failure of fusion of the S5 lamina. This question is commonly asked: which anatomical structure causes the sacral hiatus? Is the failure of fusion of the lamina of the S5. Lamina are the structures which connect this spinous process to the transverse process. So they are not there. So naturally the spinous process is also not there. So it is formed by the failure of fusion of the S5 lamina, and it is surrounded by the sacral cornua, which are nothing but the articular facets of the S5. And the sacral hiatus is an inverted U shape and covered by the sacroproccepial membrane. And you can see this, which is the median crest, which will be the fusion of all the central spinous processes. Here, both the spinous process and lamina are absent, and these are the cornua which project out. Sorry, which is nothing but the articular facet. And there is a coccyx below that also. So the membrane that covers from here, that is called the sacrococcygeal membrane. It gets attached at the coccyx level. And it is in continuity with the lumbar epidural space, contains nerve roots of the cauda equina. The dural sac ends at the level of S3 in infants and S2 in adults, higher at the adults. So when you use a caudal block for children, you should not insert the needle too deep. Then you may puncture the dura, and the drug that you inject may become subarachnoid injection and may cause a total spinal. So we have to be very careful in children not to insert the needle too deep into the space. And the contents are fat and epidural veins. In children, the epidural fat is looser and more fluid. That is the reason why it is preferable to do caudal in children. The techniques can be landmark based blind caudal epidural block. So you have to obtain consent, then the child usually under DA or sedation. Older children with the ketamine sedation, you can do it without further. Whereas in smaller children, you can do it under face mask induction and position the child and do it. More older children, after application of MLA cream in that particular location and proper counseling, they may cooperate and you can do it in a 7 or 8-year-old child. You can usually do it with the cooperation of the child. And the position is either prone or lateral decubitus. The very aseptic technique is important, and the caudal and sacral hiatus is identified by these landmarks. Both figures integrated spine combined with a triangle, which will usually end up. So it will be almost at the beginning of the natal cleft. So you don't go very close to the anal, it will be well away from anal opening. So it will be at the beginning of the natal cleft. And palpating the semi cornea, you can identify the two bony prominence. There will be a dimple in between that. You can use a 22 or 23 gauge IM needle, dual to the short dual, to perform the block. And the short profile includes the identification of the loss of resistance is very felt when we have a short blunt dual needle, and it decreases the risk of vascular puncture also. And needle with stillet avoids the risk of cutaneous tissue pouring. You do that. So in some centers they use the Venflon cannula. 22 gauge Venflon is used to puncture And once you cross the sacrococcygeal membrane, you remove the needle, gently advance the IV cannula itself so that the needle doesn't get blocked with the tissue. And so that is the another method which is used. Now puncturing technique, you can use it at a 60-degree in relation to skin. Then bevel is oriented ventrally. The distance between the skin usually is between 5 to 15 mm depending upon the size of the child. And once you cross the sacrococcygeal line, you redirect the needle to 30 degrees to skin. So this is the picture. You start at a 60-degree, come and go to the sacral hiatus, and once you hit the bone, you gently withdraw and then flush the needle parallel to the skin, then advance it a little. And this is the blind technique of doing it, how you hold and first you 60-degree, you go and hit the bone, then you gently withdraw and make it to 30 degrees and advance it. And make sure that there is no CSF or blood leakage from the needle, and there should be no resistance at all when you inject the solution. It should go in freely. And epinephrine test is done under ECG or blood pressure monitoring in cases of doubt. So normally it is not required, but in case you have any suspicion, then you can do this. Now the question the examiner asked, how will you clarify that it is not intravascular or subarachnoid? Then this is the answer for that. And subcutaneous bulging indicates the needle displacement. Blood indicates there is a venous puncture. And in case of CSF leak, you should abandon caudal anesthesia because even if you withdraw the needle and then inject a large volume there, there's a chance it can get absorbed into the subarachnoid space and become a total spinal. So aspiration should be repeated during injection. And what are all the methods of administration? Can be a single shot technique, or you can pass a caudal catheter to prolong the analgesia. What are the drawbacks of external catheter? Risk of catheter bacterial infection because it is close to the perineum. Risk of infection is there, or the catheter can get displaced. So that was the blind anatomical technique. The second technique is fluoroscopy guided cardiac caudal epidural. Here the patient is placed prone and you can use a lateral view of fluoroscopy. Sacral hiatus to be identified as the abrupt drop of the end of the S4 lamina. And the block needle trajectory can be visualized and navigated according to the into the sacral canal. So by injecting contrast fluid through the fluoroscopy, you can use this method and you can identify the stage. This is the picture that you can use. And routine use of fluoroscopy is limited by radiation exposure, cost, and space constraint. So, for the completion of answer, you can use it, but in practice, normally we don't use this particular uh, fluoroscopic technique. The third method is ultrasound guided caudal epidural block. Patient is placed prone or lateral. You can use a 7 to 13 megahertz linear transducer, and in obese patients, we use a lesser megahertz transducer. And transducer is placed transversely at the midline to obtain the transverse view of the sacral hiatus. The carnua can appear as a hyperechoic structure, and between the carnua, you will see the two band-like hyperechoic structures, which is the sacrococcygeal ligament. And there will be one deeper shadow, which is the sacral bone. And sacral hiatus is a, so this is how you first place the transducer across, and you can see these following structures: sacrococcygeal remnant, the bone, and the sacral conva. Both of them are seen. This is the sacral hiatus. So at this level, you can rotate it to 90 degrees. So after initially identifying like this, you rotate it to 90 degrees. Then you can see the entire length of the caudal epidural space, sacral hiatus, and you can immediately do an in-plane uh, uh, insertion of the needle. And this is a classic picture of this picture I have put in to make you be familiar with this so that in case it is given in the OSCE, the question will not struggle. So the names will not be mentioned there. They may just mention progress view. Then it is the identification of the caudal epidural space. And the drugs that we use are usually levobutyrogen 0.1252, 0.25 and volume 0.5 to 1.5 ml per kg depending upon the desired dermatome. And this arbitrage formula is usually the common formula that they may ask you in the exam. So for any sacral uh, or lower abdominal procedures, you can just give 0.5 ml per kg. For below umbilical procedures, you can do 1 ml, and anything that is required above umbilicus, you have to give 1.25 ml per kg. But when you use 1.25 ml, you reduce the concentration from 0.25 to 0.2 or even lesser than that. Then there is another formula, at least know the name, it is called the Scott formula, which based on the age and weight of the child, as well as to avoid overdosing obese children. Some of the adjuvants that can be added to the anesthetics are morphine, clonidine, ketamine, and dexmedetomidine. Indications for caudal anesthesia is surgical and non-surgical painful intervention in body areas for the subumbilical region downwards. That is usually it is used in pediatric, but it can be used in adults also as a method of pain relief for chronic pain. And so the procedures, so she described all these things. Uh, so these are all the things that I will do for model interview.